Is this where we ended? Yes. I talked about parathyroid gland, but I didn't have the energy to talk about parathyroid disorders. Hyperparathyroidism. Remember that in thyroid problems like hyper and hypothyroid, there's a negative feedback issue going on. TSH and T3 and T4 are going to be opposite. But with parathyroid, it's just a parathyroid hormone is abnormal, and then it causes the calcium to go the same way with it. So this is not very common. I've even questioned why we have to teach it, but it still shows up on boards. So that's why we have to. You probably will see maybe a couple of cases of this in your whole nursing career. I've seen 0. And Andrew may have seen some of his older patients that she takes care of. I don't know. So there's 3 types of hyperparathyroidism, and the cause of the parathyroid problem is what distinguishes primary, secondary, or tertiary. So tertiary hyperparathyroidism is related to chronic renal failure, chronic kidney disease, and in that disease, the patient often has hypercalcemia. So that's the effect of the hyperparathyroidism there. The person may also have a chronically low calcium level for some reason, and that causes the parathyroid hormone to be secreted more, and that it's an adverse effect, and you have increased calcium. And then maybe there is overgrowth of the parathyroid glands or cancer in the parathyroid area that is causing more release of parathyroid hormone. That's primary, right? So basically what's happening here is that the calcium in the blood is either low or normal, but the parathyroid hormone is not responding to that properly. So the body still, the pituitary still release, or the parathyroid gland still release parathyroid hormone regardless of the level of calcium. So it says we always need more, we need more, but even if it's normal or high. What else? It's increased, blah, blah, blah. And also low vitamin D plays an issue with this, so realize that in order for our body to use calcium, we need vitamin D. And I think I mentioned this before, almost everybody's deficient in vitamin D. Maybe they need to change the normal level of it. So, what else? Osteoclastic activity. So that means that the calcium is released from the bone into the blood, and you have an increase in serum calcium. All right. I mentioned last time, I think, that 99% of the body's calcium is stored in the bones, and only 1% is in our blood. So if our blood gets low, where's it going to pull it from? It's going to pull from the bones. So the manifestations of hyperparathyroidism are related to hypercalcemia. So increased parathyroid hormone is released. The body is going to hold on to and pull calcium from the bones and put it into the blood. So the manifestations are surrounded around the calcium, so the hypercalcemia. So therefore, there's lots of complications and things that go along with changes in calcium, and also some general signs and symptoms. Okay. Nephrolithiasis, right? Kidney stones. Kidney stones are usually made of calcium, right? Yep. Chronic urinary tract infections. Also, I don't know if it's on here, but now chronic hematuria. So as calcium, remember, is a metal. Remember the periodic chart. Calcium is a metal, and increased levels of it in the blood. The kidneys are very tiny capillaries in those nephrons, and that metal, calcium, tears up the nephrons if it's too high, so the patient will have hematuria along with hypercalcemia. I have a patient that I follow at the clinic. He's like 8 years old, really fun kid, and he pees bright red blood all the time. He just has chronic high calcium. I think he got started because he ate ice cream. That's what the nephrologist thinks. But anyway, so they battle that all the time. So, but the bone issues. Remember that you would have low calcium in the bone if the calcium in the blood is too high, because it's pulling the calcium from the bone. And you would have the biggest risk here is osteoporosis, which puts the patient at increased risk of fractures, right? Over time, a person with osteoporosis will have shortening of their stature, the spine will compress, the bones get smaller, and also a risk of bone cancer. So these are just some signs of hypercalcemia. Okay, there are some cardiac complications, changes in heart rate, cardiac arrhythmias that go along with calcium. Calcium is a vital element that is for cardiac contractility and induction of the electricity in the heart. PUD is peptic ulcer disease. Also, GERD is a complication of hypercalcemia. So the diagnosis of this disorder is going to be surrounded around, of course, the parathyroid hormone level, and it corresponds with the disease. So hyperparathyroid, the parathyroid hormone is going to be elevated. You don't have to remember that compensatory mechanism, right? And also, therefore, the parathyroid hormone is high. It says the blood needs more calcium, so we're going to have an increased calcium level in the blood. But then we would have manifestations of low calcium in the bones, right? That's it. Maybe I mentioned this before, ionized calcium versus total calcium. Think about it as total T4 and free T4. So ionized calcium is the calcium in the blood that is ionized, ready to be used. It's ionized, so therefore it can bind to something. Total calcium is the ionized plus all the other calcium that's being used, bound protein in the blood. Again, vitamin D. Physicians might want to look at the parathyroid glands, and they would do that like they look at the thyroid gland with ultrasound and not iodine, but radioactive studies. All right. So the purpose or the problem here is the patient has elevated calcium. So what do we need to do? Get their calcium down, right? Because there's lots of complications that come along with high serum calcium. So if the patient has a mild form of hyperparathyroidism, it may simply be these mild interventions that can be done. So increased fluid intake to help the excretion of the calcium, dilute it a bit, and then maintain the patient's activity. So the more activity that the patient is doing, the more pounding of the bones, the more calcium is going to be absorbed into the bones. So a person that is immobile for long periods of time will have osteoclastic activity, and they sometimes will have hypercalcemia, and they will have signs of bone breakdown. So you improve or promote activity in these patients. Yes.
Like hypercalcemia, you have one sign and symptom is polyuria, and now you want to increase fluid intake. Will it be more?
Right. Yeah. To help excrete the calcium. And if they're having polyuria, they have a risk of what? Fluid volume deficit. The more severe the hypercalcemia, this patient has more risk of cardiac compromise and more severe signs, so the patient may have to have IV fluids to get the calcium down. And we can also give medications that increase the calcium in the bone. Parathyroid glands can also be removed. You may be familiar with these medications. I don't know where you would have learned them before, but the biophosphonates. So these medications, they will decrease the serum calcium level, but they don't affect the parathyroid glands directly. So these medications work by increasing the absorption of calcium into the bones. Often what you're going to see is these medications are given to patients with osteoporosis. So your little old ladies are going to get Fosamax, right? Reclass, things like that. So it increases the resorption of bone, or inhibits bone resorption, excuse me. Resorption and reabsorption are different, right? You guys know that, right? resorption is the removal of, and reabsorption is putting it back into. Right? I don't know who came up with these words. Often these medications will be given PO, but sometimes they're given IV. If the medication is given IV, sometimes it's only given monthly, and sometimes even less frequently than that. This is a big deal right here. These medications are poorly absorbed. The medication must be on an empty stomach. So remember what that means, right? 1 hour before, 2 hours after meals. Usually you would tell the person to take this in the morning, early in the morning before breakfast. The key is that the medication is poorly absorbed, full glass of water, and the patient must remain upright in a sitting or standing position for at least 30 minutes after taking medication. A lot of times when we take pills, they'll get stuck in our esophagus for a little bit, but then eventually make their way on down. And that's no big deal. But in these medications, if it starts to break down in the esophagus, it's not going to be well absorbed, so you're not going to get the effect. And it can also increase complications in the esophagus if it gets stuck there. So that's a big nursing issue, is to make sure that they are on an empty stomach, full glass of water, and remain upright for at least 30 minutes. What's under and here? And esophageal or and K-con, yeah. Lots of GI side effects: nausea, vomiting, diarrhea, constipation, right? The esophagitis signs: dysphagia, right? Difficulty swallowing, GERD, acid reflux. Long-term complication of this, and I think they've actually issued a black box warning for it, which means alert, big deal, is necrosis of the jawbone. And of course, if we're decreasing the calcium level with this medication, we have a risk of hypocalcemia. We talked about the administration technique, and remember that Flomax and Fosamax are different medications, right? Quite different products. So, look alike, sound alike. They're very similar. All right. Medications or hormones can also be given. HRT, hormone replacement therapy. This also decreases serum calcium levels, and it decreases the breakdown of the bones. So in older women who decide to do hormone replacement therapy, one of the major reasons why they do it or take it is to prevent osteoporosis, which, but in this case, it's helping to decrease the bone breakdown, therefore that puts calcium into the blood. Hormone replacement therapy, maybe you learned this in women's, I don't know, but remember that those hormones have effects, especially if the person is a smoker. The older they are, the more complications they have, the effects of it on breast cancer and things like that. The hormones are estrogen that cause breast cancer. So if the patient gets breast cancer and is on hormones, that's like miracle grow for breast cancer. All right? We can give diuretics, and remember, Lasix, we think of it mostly as potassium wasting, which is the biggest deal with that, but also it decreases its calcium wasting. It increases the excretion of calcium. This medication here actually increases it makes the parathyroid hormone more alert to calcium levels in the blood. So it makes the parathyroid hormones more sensitive to the calcium level. So that's the problem in this, is that the parathyroid hormones are not responding properly to the level of calcium in the blood. So even though it's normal or high, it's still saying we need more. So this medication increases the sensitivity of the parathyroid glands, and therefore hopefully can decrease the excretion of parathyroid hormone, helping to fix the problem. And like I said, they can take out the parathyroid hormones, but remember that often when they take out the thyroid gland, the parathyroid hormones come with it. They're buried inside of it sometimes. but it's the same nursing responsibilities, same nursing implications, pre-op, post-op care. It's neck surgery. Okay, so the same nursing responsibilities surrounding thyroidectomy. We talked about these things, I think. You know what these are? Yep. You know those signs of these complications. What are the signs of renal or kidney stones, right? You learned that in your other classes. Lots of pain, right? Hematuria. Renal insufficiency, that is a kind of a chronic problem. But as the nephrons are damaged by this chronic renal calcium, they decrease in their function. Of course, being torn out by this metal in the kidneys. And chronic renal insufficiency or renal insufficiency is not renal failure, but usually with the manifestation of this is going to be a slightly chronically elevated creatinine. And you often see this in older people. Just your kidneys get worn out when you get old. But in this purposes, the problem is the calcium tearing up the kidneys. Inflammation of the kidney itself, pyelonephritis. Said cancer, so that's bone pain, leg pain, whatever. Pancreatitis, you know the signs of symptoms, right? Severe upper abdominal pain, sharp pain. And then the GI complications, peptic ulcer disease, and GERD, gastroesophageal reflux, which you should be familiar with. You realize that they do have different signs and symptoms. Related, but different signs and symptoms. Specifically around eating. All right. I think we probably talked about most of this, but signs of PUD, esophageal erosion, GERD, signs of hyper and hypocalcemia, which you probably already studied and know, kidney stones. A lot of people will say that cranberry juice is really good for the kidneys and decreases the risk. It's really not true. There's been no studies that show that it helps with UTIs or kidney function. So, but you will still hear people tell you. But it can't hurt, but anyway. What else? We talked about physical activity, the biophosphonates, stool softeners because of the risk of constipation, and of course increased risk for fracture related to the osteoporosis and the breakdown of the bone itself. Riveting, isn't it? What else? Do you have any questions about hyperparathyroidism?
It's wrong.
It's wrong.
It's hard.
Class or hyperparathyroidism? I just don't know how to make it exciting. I don't know. So, hypoparathyroidism obviously would be the opposite of hyperparathyroidism, right? So something has happened to the parathyroid glands, and they're unable to put out parathyroid hormone. Likely, this issue is from a person who had hyperthyroidism, who took out the thyroid gland, and inadvertently the parathyroid glands were removed with it. So we talked about with hyperparathyroidism that the sensitivity of the parathyroid glands is decreased, but here it's increased. So it's very sensitive to the calcium levels in the blood. I think it's an autoimmune problem possibly here. What else? Damage or removal of parathyroid glands, low parathyroid hormone. Therefore, that results in hypocalcemia. And remember that phosphate and calcium are opposite, and therefore we would talk about the manifestations of hypocalcemia.
What is
I can't specifically say, but it has an effect on the parathyroid glands and decreases the excretion of parathyroid hormone. Yes. I'm not sure, but I think it's still there. Probably more common because thyroid issues are much more common, so therefore the patient having a thyroidectomy would be probably more likely than someone having hyper. This is speculating here, but yeah. All right. So you know those signs of hypocalcemia, right? And there's some unique things that we know about this. The tetany, right? That's a manifestation, a major manifestation of low calcium. Also GI things and cardiac dysrhythmias. Remember that, again, that the heart muscle needs calcium in order to properly contract. So the patient who has low calcium will have decreased cardiac contractility and has a big risk of decreased cardiac output. The calcium level can get low for other reasons other than hypoparathyroidism. And it happens quite frequently, especially in an ICU setting. These patients often have very low calcium, and they will show signs of decreased cardiac output because we give tons of calcium gluconate to patients in the ICU. Also remember that, I don't think there's a slide on it, I'm just talking now, but that when you give a blood transfusion, but maybe hopefully you learn this, that the preservative in blood is something citrate. Actually binds the calcium, and the patient excretes the calcium because of that preservative in the blood. So the patient who is receiving blood transfusions will very likely have hypocalcemia. So anticipate it, and sometimes when the patient's calcium level is already below normal or low anyway, we've got to get after our blood cells, I'm going to say, hey doc, do you want to just give some calcium gluconate too? Oh yeah, thanks for reminding me. So remember that the blood transfusions will lower the calcium. Maybe it's sodium citrate, I don't know. But it's the preservative in blood. Paresthesias, remember that paresthesias are like tingling, right? What else? Hyperactive reflexes, and therefore hypercalcemia is hyperactive reflex, or hypoactive reflexes. Mood changes, things like that, seizures. So you have to be sure that you know how to assess for signs of tetany. There's two ways that we can do this. It's Chevostek's and Trousseau sign. And Trousseau signs is where a blood pressure cuff is put on the upper arm and inflated, and it will cause the hand to cramp. That's a positive test for tetany. Chevostek's sign is simply tapping the side of the face, and that causes twitching or grimacing of the face, and that is a positive test for tetany. I'm going to show you a video. Maybe this will be exciting.
Hi, I'm Joy Cho. I'm a graphic designer and blogger, and I've partnered with Target to do a really fun collection of party goods. I can't wait to share it.
Forgive the music. I told you it was exciting. Look at her affects and her moods.
Around your mouth. Cramping and spasms. Okay. So what is the condition that you have?
I have pseudohypoparathyroidism and illness.
Pseudohypoparathyroidism and illness.
Yeah, I know. Try the little side of the beginning. Try the last one as best you can.
See the cramping.
There it is.
Very subtle. see her lips twitching?
Can you teach with that music in the background? For the rest of the endocrine?
It would make it more exciting. I would be very distracted. So, okay, so that's how you assess Chvostek's. That's how I say it. It sounds good, right? So, of course, how would you diagnose hypoparathyroidism? That's with the parathyroid level. Parathyroid hormone level would be low, and that corresponds with low calcium, low serum calcium, low ionized calcium, and then again, the phosphate level is opposite of calcium. Of course, does it want to work? So if the calcium level is low, we have to get the calcium level up, right? So calcium gluconate is the most common supplemental calcium that you'll be giving, and it is given IV. Remember, the calcium gluconate is given over 1 gram per hour. I talked to people yesterday about a little lesson on this. So calcium gluconate, remember I talked about potassium chloride is given 10 milliequivalents per hour. This is a nursing responsibility. This is not printed on these bags. Okay, you have to know this. Calcium gluconate is given 1 gram per hour. Right? So you should know how to calculate something if I give you a question on the test. Right? So if I said, calcium gluconate 4 grams, how many hours should that go over? If it's in 100 milliliters, what's the milliliters per hour? 25, right?
Just like that.
So know how to do that. But realize that with calcium gluconate, we need a large bore IV because if calcium infiltrates, it can cause lots of problems in the periphery. So lots of IV or venous irritation. So make sure that you are assessing closely for infiltration of that IV, and make sure that before you start that IV calcium, that IV is patent. If possible, if at all possible, the patient has a central line, always bring it to the central line. Because that line is not going to, very unlikely to infiltrate. Right. So as we increase the calcium level, if the patient is on digoxin, it can increase the effects of digoxin. Remember that you need, so just think about how digoxin works as well. Increases contractility, right? How does calcium work? Increases contractility. So this person will be at risk for hypertension and cancer. All right? So we talked about how low calcium will increase the risk of seizures, so we can give them some Dilantin or something like that. One way to quickly decrease or increase the calcium level is by telling the person to, for instance, breathe into a paper bag. So that increases the carbon dioxide level in the blood, and that will temporarily increase the calcium level. We don't do this, but it's just you'll never see a physician's order that says, have patient bring into paper bag. We don't do it, but just FYI. We can use things like aluminum hydroxide to bind to the phosphate in the blood to decrease the phosphate. And we can use vitamin D. D3 is better. D3 is the best supplement for vitamin D. So probably if some of you in here are on vitamin D, make sure you get D3. That's better. It's more closely related to natural vitamin D. So therefore, we would give that because we would increase the ability for the body to use the calcium, or to hold on to calcium is what I mean. So, and then things like Tums are full of calcium. If you take 1 or 2 Tums, that's almost half of your daily intake. So. We talked about signs of hypocalcemia, and you know from maybe when you studied the thyroid, but when the thyroid is removed, you always assess for signs of hypocalcemia post-thyroidectomy with this line. The parathyroid glands may have inadvertently been removed. Calcium levels, phosphate levels, parathyroid levels. Big deal. Seizure risk with hypocalcemia. These medications are high in phosphates. The higher the phosphate, the lower the calcium. So we want to keep the phosphate down so the calcium comes up. All right. Signs of decreased cardiac output. We talked about that. How low calcium causes decreased cardiac contractility. In a code situation, often we're just going to give calcium just for the heck of it, to hopefully increase contractility of the heart. And when we're giving calcium in a code situation, we give calcium chloride. You push calcium chloride, you let calcium gluconate go over time. But anyway, how about that? Hypoparathyroidism. So the biggest deal here is really to know those signs of your calcium imbalances, which you have stored way back in your brain somewhere, so you have to wake it up and get that back. What else do I have to talk about? Cushing's, Addison's, Pheochromocytoma. Is that it? Okay. Slides. 24 slides. Okay. Let me talk about the adrenal glands. Sometimes the adrenal glands are called the suprarenal glands. Why would you think that? They sit on top of the kidneys. But we call them the adrenal glands. And the adrenal glands have two layers. So that it has an inner layer and an outer layer. So the outer is called the cortex. And it's opposite of what you would think, because I think about the core being inside. But the cortex is on the outside of the adrenal glands. And the medulla is in the middle. So in the medulla and the cortex secrete different things. So the medulla, the inner layer of the adrenal gland, secretes those catecholamines, which I've mentioned many times before, right? Norepinephrine, dopamine, epinephrine. So those catecholamines, the sympathomimetics, the depressor, so you know very well what these things do. So obviously our body releases these things during times of stress, right? So when the stress mechanism kicks in, the sympathetic nervous system is activated. The adrenal glands play a huge part in the sympathetic reaction to stress. So it increases our blood pressure, makes us more alert, gets our heart rate up, ready to fight. Okay. The cortex, the outer layer of the adrenal gland, secretes the steroids. So the mineralocorticoids and the glucocorticoids. The way that I remember this, I just realized that there are mineralocorticoids and there are glucocorticoids, and I just think of them all as steroids. So the medulla, which secretes the catecholamines, we can technically do without this if we don't have any stress. The brain and the nervous system will kind of take over this function without that epinephrine in the blood. But obviously it's best to have the adrenal medulla, right? So we talked about the sympathetic nervous system and how the adrenal glands are in collaboration with that and increase the secretion of catecholamines during times of stress. It's a sympathetic nervous system, SNS. You know very well the functions of these catecholamines, right? What are they? Increased heart rate, increased blood pressure, increased cardiac contractility, vasoconstriction, right? We give these also when a patient is in shock, right? We want to do all those things to that patient to help them have a perfusing blood pressure. All right? And and I put this here because, it increases the cardiac output, increases blood flow to the brain, makes you more alert, makes you ready to fight, right? Fight or flight. Say what? Or run. Yep. We say that the adrenal cortex, you must have steroids for survival. Okay. So steroids have a big function in the body. Remember that they have to do with metabolism and inflammation. So it helps to decrease inflammation, right? Steroids do. Inhibits scar tissue formation and acetylcholinesterase there, right? Acetylcholine. And the mineralocorticoids, again, I just think about these together as just steroids, but the mineralocorticoids have more to do with sodium and or fluid and electrolyte balance, right? And I think of that like a mineral, like sodium and all that stuff, minerals and so mineralocorticoids have to do with the balance of fluid and electrolytes. All right. So these are the things that we will talk about that have to do with disorders in the adrenal glands, Pheochromocytoma, and of course that sounds like a tumor, right? Chromocytoma. And Addison's disease is a decreased or hypoadrenal. Cushing's is a hyperadrenal, and then primary aldosteronism is too much aldosterone. So, and we'll talk about what that means. All right. How many slides do I have left now?
20.
20? 27? 24. 4.
24 and minus 4.
Do what? 19. All right. So, do you guys want to do pheochromocytoma, or do you just want to take pictures? I can give you.
You want us to twist your arm and get out of this lecture today?
We also want to have time because we have planned for Thursday to do lots of practice questions. But I think I can. Yeah. Let's do pheochromocytoma. That's it. All right. So remember, this is a tumor of the adrenal medulla. Remember the function of the adrenal medulla. And in mid to late adulthood, there is most common. So there are tumors in the adrenal medulla and increasing the production of catecholamines. So therefore, increased catecholamines, you have increased stimulation of the sympathetic nervous system, so those effects of those catecholamines. So you have an exaggerated response from those increased catecholamines. And so therefore we know that that is tachycardia, high blood pressure, severe vasoconstriction. This person, the biggest thing here, well, this can be a medical emergency because this patient can have a severely high blood pressure. I mean, you'll die from that acutely, right? You'll just stroke out. Let's see. And yes, so when you have these stress, right, emotional, physical, infection maybe, you have an increased release of the catecholamines. With that tumor in there, it even increases it more. The tumor itself actually secretes extra catecholamines. And there was one time, I think I was either in nursing orientation or I was a very new nurse out of orientation, and I had a patient that was very sick and was on epinephrine drip, and I accidentally bolused the patient with epinephrine. And probably we used to have, at the med you have those cartridges on the IV tubing. That prevents you from accidentally bolusing the patient. So when you prime, you put the right button in, and then you won't accidentally. But we used to have this old tubing that was just tubing, and you just put it into the IV pump, and I didn't have it clamped, and just a huge bolus of epinephrine ran through the patient. My patient's blood pressure, I think it was upper 200s over like 150. I thought I had killed this. So I had induced in this patient effects of pheochromocytoma, and I was really scared. but the patient, so but I stopped the epi and just watched them close, and they were septic shock or something. That's why they were on epi. So their blood pressure came on back down. But so yeah, don't ever do that. But
How do you report that? What do you do when you made a really bad mistake? You go to your blood
it's a near miss. The patient didn't have harm. But I told my charge nurse, and she was just do that again. So I've never accidentally dosed a patient with the vasopressor before since. So don't do it. All right. So you will induce this Pheochromocytoma-like effect. So again, those effects of those catecholamines, very high blood pressure, lots of vasoconstriction. So of course the patient might report a headache, right? Heart palpitations, increased heart rate, and probably irregular too. And this flank and I think that should be epigastric pain. Again, it just makes it clear that I did make these slides. But that's where the adrenal glands are, right? So those tumors can cause pain. All right. So weight loss may come from a hypermetabolic state, right? So you have an increase in metabolism continuously because of these increasing catecholamines, which increase the body's metabolism. All right. So this patient will have lots of excitation and diaphoresis and high blood pressure, and all those signs sound like what? DTs, right? So this patient will look like sometimes they're DTs. So if maybe you've seen a patient with DTs. If you haven't, you'll never forget it. And probably most of you will see that. All right. So we can measure the level of catecholamines in the body, and this method here is a really good way to measure that. So this, I'm not going to say that word, VMA, is the end product or the byproduct of catecholamine breakdown. So if this is elevated, it tells us that we had an elevation in catecholamines. Just like, for instance, what is it? Like lactic acid is what? The end product of muscle breakdown. Right? So if we have an increase in lactic acid, we know what? Muscles are breaking down somewhere. So that's kind of how this is. But it's measured in the urine. And if we're doing this as a routine test, medications or foods like this have an increased chance of causing a false elevation of VMA. The CT scan is going to visualize any tumors in the adrenal glands, and we can also do an adrenal angiography where they put dye into the adrenal glands and look at it under fluoroscopy or whatever. All right? So if there's a tumor somewhere, probably we need to remove it, right? But during that procedure, there is an increased risk of more release of catecholamines because of the manipulation of that tumor in the adrenal glands. So realize that during this procedure, the patient has a risk of a pheochromocytoma effect exacerbation. So, and that the biggest risk there would be a hypertensive crisis. So this patient has a big risk of lots of complications. And the way that we normally treat, or one way to quickly treat a hypertensive crisis is with nitrite. I think I've discussed this medication before. And remember that nitrite works by doing what? It causes widespread vasodilation. It works very, very fast. So this would be given in a very high acuity setting. It could be running during the procedure in the operating room, but also post-op and or pre-op in the ICU. And this, propranolol, of course, is a beta blocker, and it can be given before the procedure to get their body blocked down. So this medication is attached to the beta blocker. And that's how beta blocker works. It attaches to the beta receptors and doesn't let the catecholamine get rid of. So we hopefully get a lot of their beta receptors blocked, and therefore, if increased catecholamines or catecholamines are increased or excreted during the procedure, the patient will not have as much of an effect. All right. Let's see. talked about cardiac, blood pressure, cardiac arrhythmias. Pneumothorax, just remember that the adrenal glands and the kidneys are actually higher than you might imagine. They sit just below the diaphragm. So therefore, if there's surgery in that area, there's a chance that the lungs or the pleural cavity could be damaged because of the area of the surgery. And you know all those signs and symptoms of the pneumothorax. I misspelled that too. What else? Bleeding. And then after that part of the adrenal gland is taken out, or maybe a large portion of it is, the patient then would be at risk of orthostatic hypotension because the body then is not releasing that normal amount or what the body has become accustomed to, catecholamines. So the patient may have a decreased response after surgery, so therefore an increased risk of hypotension. Remember that the steroids or the adrenal glands are the effects of the adrenal glands are essential to life. The steroids are, especially. So therefore, if the patient doesn't have any adrenal glands, if both of them for some reason have to be removed, the patient must be on steroid treatment for life. Prednisone or methylprednisolone, something like that. All right, I'm not going to talk about athletes. So Pheochromocytoma, really high blood pressure. Right? Yeah. You have any questions? Yes. DT, delirium tremens. You just took mental health.
I know, I forgot, I know the DT, but I don't remember what's it.